I hated changing in the locker room for sports. I actually got an F in PE because I hated performing in front of everybody. I wasn't athletic and I hated changing. And so for a lot of kids, it's really overwhelming. And I know a lot of kids are asking for homeschooling now so that they can avoid that social aspect completely. How do you handle that? Because I know ever since 2020, where homeschooling kind of became the norm for a while, a lot of kids would rather avoid all of that humiliation, anxiety, overwhelm, and just go to the homeschool. And a lot of parents, for them, it's a lot easier just to go that route as well. How do you help parents navigate that issue with parents and with the kids? Hi, I'm Dr. Nafisa Sikandri, a licensed clinical psychologist specializing in anxiety-based disorders. I created the Mental Health Break podcast to give you simple, actionable, step-by-step strategies to help you prioritize your mental health. Mental illness can cost you time and money. Ignoring your symptoms will only make the problems worse. Taking time out of your busy day to dedicate to improving your mental health can lead to long-term health and wellness. In this podcast, you'll learn tips, tricks, and proven strategies to help you regain control of your life, all while prioritizing your mental health. If you want to improve your life, regain control of your mental health, and feel empowered, you're in the right place. Let's get started. Today's episode is sponsored by the Mental Health Reset Conference scheduled for January 13th and 14th, 2024. Secure your tickets now to ensure your place at this transformative event as seating is limited. Prepare to kickstart the new year on a positive note by joining us in Phoenix, Arizona on January 13th and 14th, 2024. Learn more by visiting transforminganxiety.com/attend, ATTEND. That's transforminganxiety.com/attend. Today, I'm joined by Mr. Ira Hayes, who is an anxiety specialist working with children. Let me briefly introduce him before I bring him on. Ira Hayes is a compassionate licensed clinical social worker with a distinguished career in mental health and education, specializing in anxiety disorders, including school phobia and OCD. As the program director at Center for Wellness, overseeing both partial hospitalization and intensive outpatient programs, he leads a team delivering evidence-based treatments. Mr. Hayes also owns a thriving private practice, Hayes Health and Wellness, and runs Hayes Marketing, aiding small practices through consultation and content creation. As an adjunct professor at Monmouth University, he imparts his mental health knowledge and passion to the next generation of therapists. Known for his expertise, Mr. Hayes actively gives back to the community in the mental health profession through charitable initiatives and volunteering. With a focus on anxiety disorder treatment, including CBT, DBT, KPMT, and ERP, Mr. Hayes uses an empathic approach and evidence-based intervention to empower his clients to conquer challenges and lead fulfilling lives. His commitment to improving mental health is evident in his diverse roles. Hi, Ira. Thank you for joining us for this podcast interview.
Hi, thanks so much for having me. Appreciate it.
Glad to have you. So I did a little introduction of you before, but I want you to kind of tell us a little bit about how did you get into specializing in anxiety with children, or how did you get into being a social worker?
So I had a bachelor's degree in psychology and realized I couldn't do a ton with that, and had a mentor early on that kind of got me into social work. I've always wanted to be more into like the clinical side of social work. And I think we're always acting as advocates, but I always enjoyed the clinical work. I actually started working with kids early on, more in like a residential setting, as that was like an easy in for me into the clinical world, and worked with oppositional youth for a significant amount of time, working using KPMT to treat oppositional defiant disorder in youth. But then kind of moved to a school-based job and started seeing the development of anxiety there in younger kids, different presentations in the kids that I was working with. And honestly, it really started with people asking me a lot of questions about how to solve different problems that we were seeing at the school, mostly related to school phobia at that time. We had a lot of kids that were coming to school and not able to make it in. And I was just trying to apply what I knew, the little bit that I knew then, about exposure treatment and getting kids into school, and then kind of building off that. Then I realized, like years into it, after probably 2 or 3 years of using exposure treatment to treat school phobia, I was introduced more to like a regular model of ERP from a mentor of mine, and the treatment of OCD. Honestly, I kind of stumbled into it because there was probably 4 or 5, 6 kids that I really struggled to work with, and I found that the skills training and stuff that I was doing with them, through exposure with school phobia, was not working. And I knew enough to know that I wasn't doing the right thing. So then that's when I really sought out more of a mentorship, with someone who knew more. And then I've just grown from there and understanding OCD and the treatment of OCD, especially with kids.
I made a mistake in just saying you're a social worker. You're a licensed clinical social worker, and there's a difference between that, right? Because you can actually do therapy, and that clinical aspect is different than what social workers do.
Yeah, I mean, in New Jersey, in New Jersey, the state that I practice, I'm a licensed clinical social worker, so that would be kind of the clinical license that you need to actively, independently, treat people as a therapist. So yeah, I am a director of a program called Center for Wellness, and then I also run my own private practice named Hayes Health and Wellness, and kind of teach at Monmouth University occasionally as an adjunct professor there. So I keep myself busy. That's that's the main thing. It's fun for me to do things like this. I do a lot of program development locally here in New Jersey because I feel like once I had this information, I wanted to make sure I was sharing it with people. Because I had success early on treating a couple kids with OCD where I probably would have failed previously. And now I just want other people to have kind of the same success that I've had, because I think the information's out there. It's just kind of hard to find sometimes.
Yes, definitely. I specialize in anxiety as well. And so I know, and I work with kids, but tell me how anxiety shows up differently in kids than they do in adults, because it's not the same thing. A lot of times, families don't know their child is struggling with anxiety or school phobia or even OCD because, like I said, it shows up differently. It's not the same as adults. So, can you just tell us the difference between how it shows up in children versus adults?
Yeah, I think with adults, when we think about anxiety, we think about our own kind of free floating anxiety and not like that acute limbic response anxiety that a lot of kids have. So, especially, I see a lot of free floating anxiety in OCD. I do, but especially like with the kids with school phobia, most of the scenarios I get called in, it's actually misconstrued as like a situation where the kid's being oppositional. So, like, I'll get a lot of calls about, a parent goes to wakes their child up. They kind of tell Bobby it's time to get up and go to school. Bobby kind of rolls over. Maybe they give him a good shake or something to wake up. And then Bobby kind of explodes, maybe throwing something and yelling, cursing, screaming, maybe breaking stuff around the house. And generally, we see it as like this act of opposition. But many of the times I'm called in for a situation like this, very frequently, and it's part of their limbic response. They are going into fight or flight, and some kids just are more likely, just like all, and similarly with adults, I think they're more likely to go into that limbic response, and that part of the fight, response is strong for them. So I think it's misunderstood sometimes. I think the anxiety is misunderstood, and then I think our treatment often, we have to adjust it, where we're not working with we're not trying to raise motivation with a kid who's school phobic, right? Motivation often is there. It's just a matter of helping them to understand what's going on in their body, creating exposure plans so that they're not in that limbic response and so that they can kind of manage whatever levels of anxiety they are having. So I think that's probably what I find to be the most important thing with children anyway. With adults, it really acts the same way. But I think the response is confusing for parents when they're watching their kids because they see anger. They don't see like what we would normally see with an adult panicking. They would see a kid meeting their needs differently.
Well, one thing you mentioned is the oppositional part. And when I was a school psychologist before I became a clinical psychologist, and I was missing that clinical piece. And my training as a school psychologist never prepared me for what anxiety and OCD look like in children. And so a lot of psychologists are putting these overly anxious kids who are coming across as oppositional into severe classrooms like the special day class or emotionally disturbed classrooms without addressing their anxiety. And I used to have this belief that this kid is never going to be fixed. I didn't understand them. They scared me.
Mhm.
But now that I'm working with children in clinical practice, I was like, oh my gosh, I wish I knew then what I know now. I would have not put any of those kids in those classrooms. That was not the solution for those kids. And oppositional defiance disorder is, I think, rooted in OCD and anxiety because their brain gets stuck on whatever they're not getting or their needs not getting met, and then they just dig in their heels and they refuse to act. Teachers get frustrated, school gets frustrated, and the easiest thing is to do is to put them away with other kids who are having trouble.
Yeah.
And that is bad role modeling, and that just makes their behaviors worse. I know you deal with this on a regular basis, so can you talk a little bit about that and what some of those experiences look like and how you've been able to do anything about it, if you have done anything about it, or course corrected or help the family to change and transition a child so that they're not heading in that direction or getting kicked out of school or getting expelled? Do you have any examples of situations like that?
Yeah, I mean, there's a lot of different time. I've probably worked with, at this point, several school districts, dozens of school districts, hundreds of kids. I think the main part of working with the families and the schools is about education and letting them understand that what we're actually looking at. Again, so like we're not misconstruing that limbic anxious response with opposition. And that once we see that and allow both the kid and the family and the school to understand that we are looking at anxiety and anxiety is treatable, right? There's a misconception about the treatment for this kind of condition, right? And I think it goes to what you're saying a little bit is very frequently people are in this box where they believe that mental health treatment is a weekly, once an hour therapeutic session with a therapist, and that's kind of the continuum of care. In the program that I work at is an IOP, we're getting 9 hours in. Sometimes with a school phobic kid, we might put a significant amount of resources in the first week or two, and then be able to not have to work with that kid again in the school phobic response. So I'll give you an example. I've consulted with a couple of school districts where they might identify some kids prior to the school year that are struggling. And what I would do is say they give me a handful of like 6 kids where they're like, hey, they had, 110 days out last year. Due to school phobia, school refusal, whatever. I usually differentiate between that. I kind of categorize that non-attendance of school into school phobia, school refusal, and school avoidance. So when we're talking about the school phobic kid, if we can get them into the school to, let's say, see me and build that fear hierarchy out, typically if they're capable of coming and seeing me, that's great. But we'll do a slow exposure plan over, let's say, 3 or 4 days where they might come before the school year starts, come and speak with me, do like just an intro session, come speak with me again the next day, do some skills training, and then come with maybe 3 or 4 other like-minded kids that are struggling with the same thing that following day, and do skills training for a few hours. And I think just by doing that, we've seen a significant increase in the kids being able to attend on that first day and then make progress from there. Generally speaking, I've worked with a couple of families and gone into different meetings where people are all very well intended. Like I've gone into, I come from where I'm living now is a rather affluent area, and I've gone into meetings where people are like, "Hey, if they come to school for 3 days, we'll buy them an Xbox." And a lot of times, everyone signs off on this because it feels good by the end of the meeting or the family session with the family and the school. Everyone's happy because, of course, this kid agreed to attend school for those 3 days, and oftentimes they will attend school for those 3 days. But what we don't understand is that if we take a kid who's got school phobia or any anxiety about anything really, and we allow them, we have them and we incentivize them kind of white knuckling it through long enough, after 3 days, if their limbic response doesn't drop while they're at school, that following week, it's going to be even harder for them to attend because what we've done is we've kind of cemented in their mind how school is scary and anxiety provoking, rather than if we did a little bit more of a progressive exposure plan. They understand that they do have anxiety and they can tolerate that anxiety, and the discomfort might grow, but their ability to tolerate it will grow as well. So I think anytime that we're building out a fear hierarchy, helping a kid do exposure to something like school phobic, like a school phobic response, it can be really helpful. The difference between the treatment I do for OCD and school phobia is I still, when we do exposure response prevention for OCD, generally speaking, we kind of avoid skills training a little bit. It's more about the exposure. So we don't want people like distracting themselves and using the typical skills that we might teach for OCD. And we can get into that if you wanted to. But with school phobic kids, I do still do a significant amount of skills training. And just the skills training and education sometimes is enough for them to feel less symptomatic and more okay with being at school. But I often talk to kids about the fact, and the families too, that we're not waiting for them to not feel anxious to come to school. We might be waiting a long time. We're waiting for them to feel confident in tolerating the discomfort that they might have those first couple of days during the exposure plan. I mean, I think working with the districts and the families is really important. Educating everyone so they know what they're looking at, and then problem solving from there. If we have a kid who's, let's say, well, I kind of categorize school phobia, and I know we were talking a little bit about OCD, a little bit back about school phobia, but they kind of all fall under the umbrella of anxiety disorders. With the school phobic kid, there's usually a performance-based anxiety, a social-based anxiety, or a little bit of both. Um, so like even providing that information, allowing the kid to talk about what's bothering them so that we can kind of problem solve and adjust that exposure plan based on what their fears are, right? So a kid who's got, a social school phobia is going to be horrified by lunch, lunch, bus rides, things like that. That unstructured time is terrifying to them. Um, so we might be able to structure a plan where they might, first be exposed to like English and math because they find that rewarding and their ego is built on being a bright person, and they can get in there and get some work done. And we kind of problem solve around lunch and gym and things like that until they're ready for that next level of exposure. And vice versa for the performance-based kid, they're almost like opposite. The performance-based kid loves lunch because there's no need to perform, but we might then do an exposure where in the fear hierarchy, it's coming to school, exposure for places, exposure for peers, and then, up the ladder a bit more is that academic pressure.
Lunch is a very scary time for kids. I used to have severe social anxiety, and I used to get so nervous I used to go hide out in the library during lunch, and I can relate to
Mhm.
the kids. I hated changing in the locker room for sports. I actually got an F in PE because I hated performing in front of everybody. I wasn't athletic and I hated changing. And so for a lot of kids, it's really overwhelming. And I know a lot of kids are asking for homeschooling now so that they can avoid that social aspect completely. How do you handle that? Because I know ever since 2020, where homeschooling kind of became the norm
Mhm.
for a while, a lot of kids would rather avoid all of that humiliation, anxiety, overwhelm, and just go to the homeschool. And a lot of parents, for them, it's a lot easier just to go that route as well. How do you help parents navigate that issue with parents and with the kids?
Yeah, I think it's a lot about an honest communication, and that might be okay for a very small portion of kids, very small part of the population. Most kids will struggle. The fear response to school will generalize at some point. So if we're having a lot of anxiety about school, and then we avoid, that is a learned behavior. So as we learn to avoid things that make us anxious, our world will get smaller and smaller and smaller and smaller. It doesn't always start with school either. It could start with other concerns and other issues, like it could be malls or amusement parks or sports fields where their anxiety begins and the world gets a little smaller. And before we know, we're treating, agoraphobia, not school phobia. But I would say that for kids that are struggling with school, not every kid belongs in a giant public school system that they get lost in, but every kid probably belongs in some kind of school system. And I would say that learning to tolerate the discomfort is part of the experience. And I don't think most of the kids that I work with don't feel that discomfort indefinitely. The majority of kids feel that discomfort for a few days or a few weeks, and in really, really severe cases, maybe a little bit beyond a few weeks, maybe a month or 2 months. But generally speaking, that discomfort reduces. They find some level of comfort in attending school, and then they find some level of reward for overcoming that anxiety. So, in general, I don't recommend there's a lot of good reasons to homeschool a child. I just don't think anxiety would be the one that I would choose. If someone's having that fear response to attending an educational thing, I wouldn't necessarily say that just avoiding that is the best bet. I think figuring out a way to treat the anxiety, figuring out a way to maybe make accommodations at school. So I'm not suggesting, a lot of times with school phobia specifically, you might have, and this is so interesting because I love talking about like the intersectionality between mental health and education fascinates me. But you might have a kid that's like, I've been called in many times, like for a kid who maybe is suffering from dysgraphia, let's say, a younger child that's dysgraphic, and a do now for this class is, write 3 sentences about yourself and share it with your peers, which is a totally appropriate do now and like a trauma informed do now for like 99% of the kids that are attending school. But for that dysgraphic kid, having to write something or trying to write something and not having something to produce to share with a peer in a timely way, if it's not addressed, if that learning problem isn't addressed, if that's not addressed with the teacher and the class and everything, that turns into a school phobic response. So again, it didn't start as school phobia. It started as like, hey, I'm having this really anxious response to writing. But then if they experience so much panic at school, then it becomes about school and not necessarily about just writing. So with some kids, I think it's a matter of just, addressing maybe the specific learning disability or the academic vigor of what they're asked to do rather than the whole experience of school. And there's a lot of options out there for kids.
And I also would agree to not only not take them out of their classroom. Let's say it's a classroom, they're having an issue, because once you take them out, then they're not going to be happy with the other class, and you're constantly moving back and forth. That's not a good idea. Homeschooling for the majority of anxious kids is not a good idea, in my opinion, as well. But also, even speaking, doing oral presentations in the classroom. The mistake that my teachers made, because I had so much anxiety, is avoiding or excusing me and saying you don't have to do it. And so after high school, my biggest challenge was forcing myself to do public speaking, forcing myself. I took a drama class. I put myself in these situations to overcome this, because like you said, your world becomes smaller and smaller and smaller the more we avoid it. And parents, without even unintentionally, can make anxiety worse because they think they're helping their child when in fact they're actually making it worse. But I do like that you mentioned the accommodations aspect of it. A lot of people don't understand, and I'm sure this is the case in New Jersey as well, because this is a federal law, the 504 plan, that a lot of kids under the 504 can get accommodations for anxiety and OCD, and a lot of their meltdowns and a lot of it doesn't have to be a learning disability. It could just be they're super anxious and super OCD about certain things, which impacts their behavior. So can you talk a little bit about some of the accommodations that parents can ask for or advocate for their child?
Yeah, no, I think accommodations is like a really important part of the intersectionality between mental health and education. I think one of the things that I try to stress is that our goal, I am a parent myself. I have two young boys. And I think one of the things that we misunderstand is that making kids comfortable is making things better. And I don't think that's necessarily true. Comfort is not the goal. Empowerment might be the goal. Building some success might be the goal, but I don't think making things easier or comfortable is the goal. In terms of accommodations, I think there's certain particular things that are really helpful. So for a school phobic kid who has performance anxiety, for example, right? I've seen situations where, a lot of times on a 504 and IEP, they'll have multiple choice questions as an accommodation. And for years, I really didn't understand why until I started getting into the kind of the weeds with school phobia and that performance anxiety. And if you ask like a kid with performance anxiety about, what subjects they struggle with the most, many of them, being a social worker and a therapist, I always assumed that math would be most difficult because I struggled the most with math. But what's interesting about it is if you ask a lot of the kids that I work with, math is a little bit simpler for them in the sense that, like, if you say 4 plus 4 is 8, they can go find reassurance, they can double check themselves, they can make sure that it's 8, and then they could probably rest, right? So this kind of is that performance-based school phobia, and it might be slightly more in the OCD realm or the obsessional thinking and perfectionism in terms of seeking reassurance, but they can seek that reassurance and find it. But if you ask a child to let's say identify their favorite color, the performance-based school phobic kid is going to struggle with that in the sense that they'll kind of have this thought process is like, well, if I say red and I mean red because I have love, but people think I mean hate, or what if I say red and they think it's blue, I should have answered blue. So something as simple as like a multiple choice question can make that class so much easier for a short amount of time for a kid to get them more comfortable being in class, participating in class, rather than having the fear of judgment over a subjective question. They can answer the question and hand it into a teacher and then feel confident in their answer if it's a multiple choice question. So little accommodations like that can be really helpful. I think one of the things we expose for in school is time and duration. So, I don't think that it's realistic that because a kid can attend for an hour, that they'll be confident and feel comfortable attending in 7 hours of school. So I think an accommodation around duration for a short amount of time. And I think that's where I struggle with, how do we do this without, some schools want to amend the IEP. And I don't think necessarily that we're talking about, 10 months of a shortened day. I'm talking about maybe 2 or 3 days where we can expose for duration. So like, hey, today we might be doing 1 hour in my office, then tomorrow might be 3 hours in the school. That might continue for a couple days until they feel their anxiety levels coming low enough that we can then extend the day a little bit longer. So I think, duration, and there's so many specific cases where accommodations might be helpful. I think training is also really important. Like for a student with OCD, who's, let's say, seeking reassurance 20 or 30 times a day. It's not really like a specific accommodation, but it would be something where everybody within, some responsibility of their care would have to be educated enough to know that, hey, every time I provide reassurance to this kid, and it's really tough to understand because a kid might come up and say in the classroom, like, am I okay? And everyone's instinct might be to be like, of course you're okay, Bobby. Go ahead, sit down. You're safe here. You know that it's safe here. But every time we do provide reassurance for that OCD student, um, we're making it worse, essentially, right? So we're providing them the reassurance, and then that requires them to then seek more and more reassurance in the future. So again, I think it's very it's different across the spectrum of needs. Each accommodation needs to be really evaluated pretty carefully. When we're talking about OCD, something like that, like we really have to provide a lot of education to the staff, a lot of education because what typically happens is, and again, this is all, I probably should have started with this, but like, obviously, I'm sure you're aware, but for anybody that's listening, we have to have consent. We wouldn't just do all this without consent from the student. So like a student would need to be consenting to exposure treatment for us to like withdraw like to kind of, because exposure without consent is basically torture, right? So like if an OCD client isn't down for exposure treatment, we wouldn't do this. But, uh, you know, if they're seeking reassurance in class, we're going to try really hard not to reassure them. And it's just second nature. I mean, as a parent and as a therapist, I still get caught sometimes. I had a student once walk out of my office who we had this wonderful session. It was really doing quite well. And then they walked out of the session and kind of said, do I go left or do I go straight? And just instinctively, I said straight, you know? And then I realized then in the moment that she caught me off guard, like that I provided her reassurance. She knew exactly, she'd been out of my office 40 times, that I provided reassurance. So I don't think perfection for the schools or the parents or the families is ever the goal. I think being aware of what accommodations might be helpful, and then, attempting to kind of constantly be evolving to help that kid is probably more important than amending a specific IEP accommodation or 504 accommodation.
What I like about accommodations is it provides that safety net so that they're not penalized for their anxiety and their OCD. So a kid that's having trouble coming to school, obviously we don't want to encourage and make it okay for them to constantly be absent. But if they truly are struggling, it's not held against them. If a kid that has OCD and they keep ripping up every paper that they start and they can't do it and it doesn't, and they need extra time to finish a task because they just cannot write one draft, that's an accommodation. It's not perpetuating the problem. It's just, and what I love about a 504 plan or an IEP is every single person that comes in contact with that child has a blueprint of how to work with this kid, so that they don't have to guess like, oh, Tommy's asking for reassurance. They don't know that Tommy has OCD, but if they had the blueprint, they would know this is what he's doing and this is what I need to do. And that's what a lot of people don't understand. They're like, well, it's a crutch, it's a handicap. We're making our kids handicapped by having these accommodations. It's just creating a safety net for everybody involved so that that child can feel comfortable blossoming as they're growing their skills and learning alternative ways of behaving. So I do want parents to look into accommodations if their child is struggling, but not at the expense of like disabling them. I don't want that mentality like, oh, poor Tommy has anxiety, he can't do anything, therefore we need to wrap him in bubble wrap and put him in the corner. Right. And that's the accommodation. I'm not saying that at all. It's a matter of Tommy doesn't even have to know he has accommodations. It's just the staff knows how to work with them so that they're not perpetuating the problem.
Yeah, no, I think if people looked at it like they were thinking about like coaching or anything else, right? Like if I'm going to try and run a marathon, but I have tight hamstrings, right? An accommodation might be, time to stretch before I work out, or a certain kind of, I might be coached on a different way to run. No one's telling me, hey, you don't actually have to run it. You could just walk to the end and get a medal. They're just kind of coaching me and helping me get through some of my pain points a little bit easier. And what I think is amazing is like some of the kids that I work with that are school phobic or have any of anxiety, once they resolve the anxiety to some extent, obviously the goal is never for anxiety to be gone. That would be impossible. But once they learn how to manage it, um, it's amazing what they can accomplish with the same grit and vigor that they attack their anxiety with. And it's like if they put all that energy into solving their anxiety, then when the anxiety is gone and they put that into the academics, I think teachers and families are often surprised by like, oh my gosh, they had so much in them that they were using to kind of combat their OCD. And now that this OCD is gone, or I shouldn't say gone, but controlled more or worked on, that they're able to focus. And I think that's where I get excited because I see the positive aspects of it pay off. And I think what's great about treating anxiety, I mean, I treat the whole gamut of, mental health, but I think what's great about anxiety for me anyway, as a clinician, especially with things like school phobia and OCD, is it's kind of almost concrete more so than like depression, right? Because depression, there's this continuum of happiness, right? And like, no one's at 100 all the time. Where if you have somebody with like OCD and they are, spending 4 hours on rituals, and we get it down to 11 minutes, like it's very measurable and you can see your success like right away. Or, if they can't sit and they can't do academic work and now, within weeks they can. To me, that's why I enjoy that work and I enjoy exposure work because you do see they reap the rewards pretty quickly, as opposed to maybe some other things where they might not reap the rewards so quickly.
Well, I go as far as to say that OCD and anxiety can be the best disorder in the world, because what you're saying is we're using it to make it work for us instead of being controlled by it. I look at it as a two sides of it. Either we're being controlled by it and it's bullying us into doing things we don't want to do, or we take control of it by getting in the front of the bus and driving that bus instead of just bopping along and just panicking and freaking out because we're not in control. But once we learn how to control it and make it work for us, it can be amazing because society rewards us because of how diligent we can be. We make great students, we make great employees because we work really hard and our anxiety pushes us to do the best work possible. So once we learn how to make it work for us, it can be an amazing blessing. And that's why I like to work with people with anxiety and OCD, and I specialize in it. And I've learned to really value my own OCD and anxiety because I use it to help me accomplish my goals and do a good job because it'll never let me down. My standards are a lot higher than what most people would expect, but now I'm in control of it as opposed to feeling overwhelmed and debilitated by it because I'm not in control.
Right, right. Yeah. I think a lot of the people that I'm working with often, as their symptoms subside a little bit or they have control over it, they tend to feel like empowered by the fact that, they struggled with this and now it's something that they deal with. But, even the same with a lot of kids with ADHD, once they learn how to manage certain particular symptoms that are more difficult to deal with within the academic system, then they can kind of, and I think we're seeing that more with adult ADHD when people are talking about it. But like their ability to hyper focus on things becomes like, there's some talk about it becoming like some people's superpower.
Exactly.
Not to say that it's wonderful to have ADHD, but certainly that we could take that there are particular aspects of things that help us. And if we view them differently and manage the difficult parts of them better, certainly we can be more fulfilled than ever before. I think that's important to focus on, I think, for a lot of kids, because they want hope, they want excitement, they want to feel as quote unquote normal as possible despite any kind of anxiety or neurodivergence that they might experience.
Well, even would even talk about learning disabilities. There are a lot of different ways your brain works, but if you feel like this is a disability, this is why I'm not into labels so much. Even with OCD and anxiety, like you said, all of these issues can be awful to have if you don't understand it and you don't know what to do with it. But like ADD can be a superpower. You can be spontaneous and fun, but once you learn how to make it work for you and not allow it to control you, it can be a good thing to have. But first, you have to understand it, and you have to work on making it work for you and overcome it, and then you can reap the benefits of it, like you said.
Hmm.
But what, like, even with learning disabilities, when I would work with a lot of children, it's like, this isn't a death sentence if you have a dysgraphia or uh, auditory processing or visual processing, because you can find ways to compensate for it. I would always talk about celebrities that have these disorders, but yet they're still successful. They're still, like Tom Cruise has dyslexia. He can't even read very well, but yet look at all the movies he's done. He's learned how to memorize. So it's a matter of giving them compensatory skills, giving them the tools how to work around it, make it work for them. And that's
Yeah.
all that I want people to understand, instead of feeling like, oh my gosh, I have anxiety. I don't know if you get that chance. I know when I was working in the schools, I only had 20 minutes with a child. So I hardly ever work with the parents that often, except for meeting at an IEP meeting. But now on the clinical side, I make a huge uh, focus a lot on nutrition, on sleep, on lifestyle. And so, how much of that do you think contributes to OCD, anxiety, school phobia, any kind of issues in the school? And then, how do you address that with the parents and families?
Yeah, again, I think it's different with all kids. So I think it plays a different role for different kids. Certainly, I think nutrition, exercise, sleep play a huge role for every person. Whether they've been diagnosed with something or not diagnosed with something, for every kid, for every adult, I think these all play a significant role in their overall happiness and health. And I was lucky enough, the school that I worked at, I mean, I've consulted with different schools, but the school that I did work at was a therapeutic school. So I had significant time. I got, an hour of therapy in with each of the clients. And then once I was supervising other people, they would be meeting with the clients, and I was able to kind of oversee how occupational therapy and stuff worked into the clinical problem solving and solutions. So I do think movement also, especially more related to, in my opinion, like anxiety, yes, it's very important. But even with trauma, there were kids that I know that were in such a hypervigilant response related to trauma that, their amygdala is completely taken over and everything else was shut down. And it was talking was not going to solve anything at that point. And I was able to have support from an occupational therapist, too, there, that were fantastic, that were able to kind of physically de-escalate the limbic response and then bring the person down into a calm enough level that like we could then start talk therapy. So I think that the connection between mind and body is imperative, especially with trauma specifically. With OCD, I think there's definitely kids that experience, dietary issues are imperative to kind of rule out as a problem with any, I think, mental health concern. Diet and exercise are really important. I think, especially, if you have teenage boys who, need exercise or are depending on, testosterone in puberty, like it's great to have them exercise of some level. In terms of sleep, I mean, sleep hygiene is so important. And aside from just being told that it's so important and feeling it myself, I think I've had a lot of kids in the school phobia realm that kind of talk about sleep disturbances and that being a difficult thing to do. I think sometimes as clinicians, we focus on falling asleep too much. I find that a waking routine is probably equally as important as the when we fall asleep. And it often self-regulates. So like I always tell, even with the adult clients that I work with, if we wake up and set an alarm and wake up at the same time every day, if you get up and you wake up at 6:30 in the morning and you go for a 40-minute walk and you're eating healthy, you're more likely to fall asleep and get the sleep that you need at night. It's not a fix for everyone, but I think for a majority of people that have sleep disturbances, a wake routine is equally as important as a sleep routine. I think it really is important though. The dietary part, I think, I'm sure there's probably nutritionists that know a lot more than me. I think the difference is like I just know that when people are eating somewhat healthier, that are consistent with their hormones, and their needs, like, and they're getting enough of like the micronutrients that they need to survive, and to be healthy. Like I would hate to see a kid that's like suffering from depression and we treating them for depression, and the reality of it is like they've got a vitamin B deficiency or a thyroid problem, and here we're treating it for depression, and it's none of the above. It's like something totally related to their diet and exercise. So I think it's definitely. I don't rule anything out. Typically, as I'm talking to a client, I don't care if they're 11 years old or 55 years old. I think their sleep, diet, and exercise are like some of the first things I'm screening for to find out. I think it's particularly interesting with treatment of like ADHD, though. When we take like a 6, 7, and 8-year-old kid, we go back 200 years. They would have been working in a field, helping with a farm. They would have been active most of the day.
Mhm.
Um, and just the last, depending on your belief system, hundreds or thousands of years, that's what we would have done. They wouldn't have been in a schoolhouse for 7 or 8 hours a
Um,
day at still. And then pumped full of refined sugar. So I do think that plays a big role into a lot of anxiety, OCD. I think addressing it is probably, I know there's some people doing like, elimination diets and stuff to kind of help kids. And I think that's probably all a way to look at for the future to see how it affects people's mental health for sure.
well, what really helps a lot of my patients is not having school lunches and sending to school healthy, nutritious foods that the child can have, but also starting the day off with a healthy breakfast, maybe a protein smoothie or maybe a protein breakfast, getting enough protein so that their brain can function. What a lot of people don't understand is how hard our brain works during those hours. And these kids' brains are so active, that's burning a ton of energy. And instead of giving them the nutrients to utilize and for their brain and gut to function optimally, we give them sugar, we give them things that burn really quickly. And then so they go through this roller coaster of sugar highs and lows. I had one patient, he had no idea he had insulin issues. And so he wasn't diabetic necessarily, but his diet was contributing to really high spikes in insulin. And once they did the elimination diet, they changed it. He became a much calmer, more reasonable child. And that's what a lot of parents don't look at. They just trust the fact that my parents did the same thing, that school lunches are supposed to be healthy, but they're not. And I think parents need to do better when it comes to sending their kids to school with healthy foods and also starting their day off with breakfasts that are actually nutritious and not just a bowl of cereal that's going to spike up their blood sugar and then they're going to crash by the time they get to school. And vitamins, I'm a big proponent of vitamins, like healthy food-based vitamins, or I mean, none of these like synthetic vitamins, but healthy food-based vitamins that can actually supplement whatever they're missing because they're not eating as well as they should. That's what I really focus on with the kids that I work with. But also, how do you support the parents? Because at the school level, I know in your private practice it's different, but at the school level, we don't have a lot of interaction with the parents because we don't see them on a regular basis. I mean, in my office, it's a lot easier for me to work with them and help them help the kids. How do you support the parents in your work with the kids in schools?
I think it's really about inviting collaboration. And I know this is something that I provided, when I am consulting with a school district, and I've done this a couple times where we set up like some kind of, parent partnership program where parents can come to like free trainings. When I was school based, I offered it like once a month. I would stay late and kind of work with some of the parents on different diagnoses, different treatments, just anything of interest. If I didn't know enough about it and they expressed interest, I'd have somebody else come in and do a speaking about it. But I think just providing as much education as possible and asking and inviting. You can't really, like you said, it's a little bit different because I think some of the mental health, and I don't want to call it a burden, but for lack of a better word, I'll call it a burden. The mental health burden has fallen unfairly on the schools in the sense that a lot of the guidance counselors and stuff like that weren't trained necessarily to deal with a lot of the specific mental health concerns that they're being asked to address now. And I guess that's why they call in consultants and hire mental health coordinators and do all of this, which is a great step, I think, in the right direction, depending on where you're living. Um, but I think getting those parents in to collaborate is most important and letting them understand that, like, I have found that I was lucky enough when I was working at a therapy school, there was a lot of collaboration and there was like meetings in which we kind of designed it to be that way. So that the parents, administrators, counselors, and kids were in the room at the same time to kind of discuss, what was best for this kid. So I think, would that work as well in a public school? I don't think I've seen it work as well in a public school, but I think when you invite people that might be interested or if they have a child that is affected by something, and you invite them kind of as a form of collaboration and not like, hey, I'm just going to educate you and you're the parent, we're the expert, but more like, hey, let's have a discussion about this. What are your desires for your kid through the academic system? Like, what would you like to happen? And then here's what we can offer. Um, but I think, just being as transparent as possible about what our intention is for the child, and, coming from a very collaborative approach. Often I find it like it's set up as like adversarially, parents versus the school or parents versus the school district. And whenever I think that's one of the advantages of being a consultant at times is like, you don't have that relationship. You're kind of that third party, like, so you can kind of break through that adversarial relationship and just say, hey, let's talk about if you want, Bobby to get to point C, what does A and B need to look like? So I think offering a parent partnership type program for any school district is probably a really good start. Just like one night a week or one night a month or one night a quarter, whatever it is that you can do, in which they have an open opportunity to ask questions, get answers. I was just recently, I thought it was pretty cool. I got invited to a back to school night in one of the local high schools, and they had like a little wellness fair at the front of the high school. They had, a couple outpatient providers, and the program again that I work for was able to kind of set up a little booth and give out a little information. And when we were talking about it, I didn't think we were going to connect in particular to any one youth, but I think it was a really large school, and the idea was that, hey, if we can continue to be present, right, and destigmatize the idea about talking about mental health at school, that's even better, right? So like if we're, regardless of what the outcome is of this, if just people see us talking about mental health, the people walking by, that is destigmatizing, and it'll be helpful for the parents to then be able to say like, hey, you had this mental health thing here at the school. I've been lucky enough that I talk a lot about, like, there's in New Jersey, one of the counties that I live in is like Monmouth County. So they had like a county initiative where they set up like a mental health night where they had a speaker come and breakout rooms. And I was able to kind of work with a bunch of families and teachers and educators, just anybody that had interest in mental health. They were able to come through this fair. And like, again, it's kind of cool. It's like a wellness fair. It's not necessarily like, hey, mental health or, pathology or anything stigmatizing. It's just like, there's a lot of people involved in the idea of like, how do we get the kids more well? So I think things like that can be super, super helpful for a community. And like, if a school needed anything, they could reach out to me. I'd be happy to like, touch base. They could email me or call me. But and I think as practitioners, we have some responsibility too. That's something that I've taken pretty seriously, like the last couple of years. With the school phobia, I kind of learned about school phobia when I was working school based, and then moved away from school based, and I didn't want that to go away. Like, I didn't want to be able to practice that information. So I've kind of set up in my own kind of home state where Center for Wellness kind of scholarships me to like go out, like as their director, I'm able to go out and give these presentations on school phobia for free. So I'm able to go to a school district, and if there's 8 or 10 guidance counselors in that school district that want to learn about it, they kind of sponsor me to go out there. I go out there, I train all their teachers and staff or guidance counselors, anybody who wants to come. I've had superintendents come. It's great. It takes about an hour to kind of give them the general gist of like, hey, this is what you're going to do, and if you need anything else, let me know. So I think as counselors, we can kind of have more of a go-giver mentality and say, like, it's not all about like making that $500 presentation fee or $10,000 presentation fee, but going out, it's it's just the right thing to do. I think is just to give a little bit away, let people know what's going on, and if very frequently it helps me out in the long run anyway. In the terms of like, if the school has 10 kids they're struggling with, and I teach them and they can help 8, then the other 2 that they need help with, they typically call me. So it's not like it's beneficial for everyone to go out and just give back to their community a little bit.
Yeah, like when I was a school psychologist, especially when I was a really young school psychologist, I didn't understand a lot of these clinical things. I didn't even know how to read a DSM diagnosis. I didn't even know how to read a psychologist report. That was not what I was trained on. I was trained on learning disabilities and writing IEPs and testing and all of that. And so when I would have these difficult cases, I would follow along what the state and federal laws expected, like put this kid in special ed, diagnose them with this, and write these goals for them. And none of that was helpful. And I wish people would, somebody like me that's gone on the clinical side would go and train these young psychologists, young school counselors. This is what the clinical anxiety looks like. This is how it shows up in the schools. This is how it shows up in the
Right.
classroom. These are some accommodations you guys can do. Because schools that are putting out the school psychologists, the school counselors, the social workers, they're not going to teach them everything before these students graduate, right? So the burden falls on the practitioner to learn these things. But if you're already overwhelmed with so many things that you're doing, you're not going to go out of your way to learn all these things. So if somebody can come in and actually talk about it, I think that could make such a huge difference. And I'm glad that you're doing that, which is, I'm sure it's helping a lot of clinicians and a lot of practitioners in the schools to serve the kids better.
Yeah, no, I thought it was important when, especially the timing of it, really. Like when I first started studying school phobia, no one really cared because it was like a very small portion of kids that were coming to me to get help for it. And it wasn't
Mhm.
until after COVID that like a majority of people started saying like, hey, this is a real problem in our school. We've got, we usually have like maybe 8 or 10 kids that, were defined as truant at the time. And now we've got, 67, or 130. It's just important, I think, as clinicians to like go and do as much as we can to kind of provide information to the other people that need it. We might spend 7 years or 10 years trying to figure something out. Why make someone else spend that same 10 years?
Right.
Believe me, Beck and all these other people, Mnuchin and, everybody gave me all their information. And then if I have something that might be fruitful for other people, certainly that might be helpful for them. And my mentors have done the same thing. My friend Ross, who is my mentor in OCD, basically just said, "Here, I'll teach you." So it's a nice it's it makes it better if everybody in the field is like that, just kind of sharing what they know.
Definitely. I totally agree with that. The more we talk about it, the less stigma is going to be around this. Because if we generalize, there are a lot of people after 2020 that had anxiety about going back to work. And one of the number one reasons people had anxiety about going back to work is to use the public restroom. So if adults are having an issue with that, imagine what the kids are dealing with. Their frontal lobe is not fully developed. They don't have good processing skills. They don't have good problem solving skills. And so they're doing the best they can at the school level, at the elementary level, high school level. These are adults that are struggling with social anxiety, with using public restrooms, with having
Yeah.
presentations, with even being in a meeting again and interacting with their colleagues. So anxiety is definitely a huge problem. And the more we talk about it, the more we normalize it, the more we give people the tools on how to manage it and give them hope that it's totally manageable. It doesn't have to be debilitating for anybody. But it's just a matter of saying, okay, I have it, and then I need help. Help me.
Yeah, I think it's especially important with like like I can't tell you how many kids or adults even that like when they come to me and they're like and I say, do you ever fear throwing up? And
Mm,
they're like, yeah, it's like a major concern for me. And they're like, why? Is that a thing? And I'm like, yeah, it's a thing. A lot of people have it. And they're comforted by the idea that like they might spend 10 years. Like average person with OCD, it takes them about 11 years to get an accurate diagnosis, they say.
no, I know.
So, for me, I can't tell you how many kids that I've worked with now that have been totally, we didn't get too into the OCD part, but like as part of the education that I do, I think it's really important for people to understand that like a child with OCD or an adolescent with OCD, it doesn't always look the way you think it's going to look, right? That kid who's having, intrusive thoughts about pushing their friend in front of a bus, that aggression OCD, that people are fearful of that. And, often I get calls about that. Like, what do we do? And I'm like, well, let's talk about it because give me 20 minutes to interview the kid. It's more than likely OCD rather than something else more dangerous or concerning. But when I talk with kids about OCD and about aggression OCD or pedophilia OCD or just any one of the contamination OCDs, and they're like, other people have this, and
Mm,
you're like, yeah, it's actually more common than you think, and they'll ask like, have you treated this before? I'm like, yeah, I have, and this is what we could do, and this is how we can get better from it. And it's just sometimes that first session, there's just such a wave of relief knowing that what they were suffering from wasn't something that they're going to suffer from like forever.
And I love that young kids are getting treatment for these things. So they're not struggling and suffering until they're in their 20s and 30s, like I was. I didn't know what I had. I didn't know that I was struggling with this stuff. And I wish that somebody would have explained it to me at a young age. So when young kids come to me, That is my goal. It's like, I'm so proud of you for doing this, because then you're stopping yourself from struggling when you're older. And the younger they start, if the parents are noticing certain behaviors, get them the help that they need. There should be no stigma. Why would you allow your child to suffer and struggle and force them to fall into a normal category when they're really struggling at that point?
A lot of parents, and this is why I think things like this podcast are so important, because I think a lot of parents don't even know what to look for.
Yeah.
They don't realize that if your kid's seeking reassurance, 30 times a day, they think, oh, they're just like a little insecure, they need a little help. But the reality of the situation is that it's likely related to OCD, related to reassurance OCD, and there's treatment, and we can help them from there. I do see I think I forget the statistics, like 20, 22, 25% of the kids, prior to 14 have, symptoms. But I say in my practice, I think I'm seeing, and I'm not sure if we're just being more aware of what it is or if there's actually more occurrences, but, in that like kind of like 7, 8, 9, 10, 11, I'm not sure if the anxiety or the stress of the pandemic had anything to do with it, but I do see more kids coming in with more symptomatic behavior related to anxiety and OCD in that age group than I remember anyway. And it could be just my personal experience, but it seems like to me, and talking to some of the other professionals, that it's an experience that other people are sharing too, that they're like, no, we're seeing a lot more kids in that younger, which I think is great that we're seeing at 8 or 9, we're able to address it. We're able to get some exposure work done early on, and then they're not suffering, to their mid-20s with symptoms that could have been alleviated or at least managed differently earlier on.
I do also want to mention that a lot of kids with OCD gets falsely diagnosed with autism. And so a lot of these kids that go for 10, 12 years of actually getting the OCD diagnosis, they will go through all of these other diagnoses before somebody would actually say, you're struggling with OCD. Like, I get a lot of bipolar, a lot of autism, a lot of other issues that have just generalized anxiety disorder, when really the issue is their brain is getting stuck and they need to work on the OCD aspect of it, even though it all falls under the umbrella of anxiety. OCD can look a little bit different, and so it can be more debilitating for some kids. But I've noticed that a lot of kids get falsely diagnosed with autism when really it's OCD. And maybe it's vice versa. Maybe there's some kids that are autistic that get diagnosed with OCD as well. But it's a matter of being really careful about treating it the right way instead of just sticking labels and seeing what sticks.
Yeah, no, I think honestly, I've been doing this a while and I still get confused by it sometimes. I'll be working with a kid and sometimes I come to the conclusion it's not an either an or, but sometimes both. That I am working with someone who's affected by the spectrum and I am seeing someone who's definitely having obsessive and compulsive either thoughts or behaviors. I think it really just, unfortunately, it takes like, I think a trained eye and sometimes some patience to kind of come up with what's really going on. But I do see that the misdiagnosis a lot, or we just say like it's kind of anxiety. And what I think can be detrimental is probably more even detrimental than that is when people see it as anxiety and then go straight to skills training. And without understanding, the kind of complexities of OCD, they might be trying to help and teaching different coping skills, especially, in New Jersey, I'm pretty sure everywhere, DBT has become very popular lately. And I've been trained in DBT. I use DBT for other clients. I think it's great. And it's a great resource. The idea of, mindfulness can be really helpful, but also a lot of the skills that we teach in DBT, I wouldn't recommend for OCD, like some of the stress tolerance skills and some of the, distraction techniques that we might use with a client in DBT are probably counterproductive for the kid who has OCD. So sometimes I think it's an interesting battle because that kind of like they're right in the idea that it's anxiety, but wrong in the idea that like sometimes the treatment prescribed, even despite that, are I've seen a lot of kids going for just like work trying to challenge cognitions related to OCD, and these kids know that what they're saying is not real. They'll spend 2 years somebody trying to challenge the cognitions, but the reality of it is it's just the wrong treatment for the diagnosis.
I don't know if things have changed in the school settings, but the only thing we really did at the school level was behavior management, just only focusing on the behavior management of it. And that's not going to be enough either. And this is why so many of these kids continue to struggle and they have meltdowns and they end up getting into more restrictive environments because nobody knows how to work with them and help them.
Yeah, no, I think especially with school phobia, I think this, again, I find it a little bit different with the skills training. I think skills training is helpful, but when I'm working with clients with OCD, I think really the main bulk of the work that has to be done is with the exposure, with the fear hierarchy, with understanding that not so much that the what they fear is not going to happen, but that the discomfort they're experiencing is not going to last forever,
It's
and
not
that
going to harm them.
they
Yeah.
can right, they can tolerate it. So I think it is, and it's hard because the adults that are at the school are probably looking at them and just saying, like, we don't want this person to feel so uncomfortable, and without knowing specifically what to do. That's why I would always advocate that if schools have kids that they have either been diagnosed with OCD or they're concerned about them having OCD, is to reach out to someone locally that knows what they're doing with OCD specifically, and connect with them and find out what can they be doing in the classroom when the kid does A, B, or C. Because there's probably a very specific thing that they could do that would be helpful almost immediately, if the kid is struggling with a specific obsession or compulsion at school.
And
Uh,
not all schools are equipped with counselors, especially in Arizona here. We don't have counselors at every level. The counselors don't have enough time to work with the kids. They might not have the training to work with the kids. So this is why it's so important to reach out to a trained mental health professional outside the school and work with them. Like I work with the parents and support them to work with the teachers and work with the school. And if the teachers have questions, they will call me and I will be happy to educate the teachers. But it doesn't have to be all or nothing, either or. It's not like everything has to be taken care of at the school or you just go to therapy. They can work together and they can collaborate. And if your kid is not getting their needs met at the school level, because it's not the school's fault, because they're dealing with way more mental health issues than they ever have before. Like I literally, when I did my postdoc, when I did it at a school setting, I thought, I'm not going to get any major mental health issues here. It's not like a mental hospital, right? But I ended up getting schizophrenia. I had severe OCD. I had suicide. I mean, I had major issues at the school level that I didn't think I would deal with. And so a lot of people are not trained, and you can't blame the teachers for not knowing what to do. You can't blame the principal, the school staff. They're not trained in that. And so it's so important to find a trained professional to help your child outside the school, and then work with the school to make sure that their needs are met within the school setting.
Yeah, no, 100%, 100%. And I think, to take it a step further, I think, there's probably a lot of therapists that listen to your podcast. And I think, taking that extra step, like not just with school phobia, but I just did recently, the School Counselor Association of the county that I live in had a meeting and I was invited to talk about OCD and give just an hour of like, hey, preliminarily, this is what to look for. And it's an hour out of my day, but I mean, think about it, there's 26 counselors in that room that can then bring that information back to the school. And when they're talking and they're maybe rounding those kids, and I know they don't round it like traditionally like a hospital unit or something, but that, they're just bouncing things and they might say, oh my gosh, you know what? Ira talked about that one time. And maybe we can, so that they have an idea of like, hey, what is it that they should be looking for?
Yeah.
So if you're a counselor and I think you have an expertise in anxiety or OCD or school phobia or anything else, offer up some of that knowledge to the people that are around you so that they even know what to look for. Because you're right, I don't think they have the training. My wife is a therapist as well and works at a school. She's a mental health coordinator at a school, and I think I think schools in New Jersey are really moving towards that, a model that's very inclusive to mental health services. I know that's not across the board necessarily, but in New Jersey it is, and they're actually hiring a therapist in the school to kind of help guide some of the more clinical interactions with kids. I mean, you're talking about what, 20% of the kids probably in a school, so you're talking, it's a significant portion of kids that at some point are going to experience some kind of mental health concern. When you add up, ADHD, OCD, anxiety, like when we add everything together, not to mention, the 65% of the kids are going to have, an ACE before they graduate high school and having to deal with that.
So I think that number is a lot higher than 20%. And that's why the schools are not ready for it.
Yeah. I mean, that's like low end. Like if you were to say like kids at any one point, but I think you're right. I think the number of kids that need assistance is probably way larger than that.
Mm-hmm.
I think that's probably where they could probably get clinical interventions from. 20% might be like an intensive outpatient program or like, like something more clinical.
Right. And I noticed that schools on the East Coast tend to be more proactive with stuff like that. There's not a lot of funding. The more you go west, the less the funding seems to apply for mental health issues or special ed or anything like that. So uh, I know when I worked in California, there was a limit that they didn't have counselors at the school levels to help the kids. Although I was a school psychologist, I also got my degree in school counseling because I really wanted to do the counseling piece as well. Little did I know that I would only get 20 minutes with each kid. So I realized that that's not really going to be beneficial. And that's why I did pursue my clinical degree, so that I can do more therapy. But staff are limited. There's only so many hours in a day, and they're supposed to meet so many requirements. And pulling them out once a week for that 20-minute session seems like a huge burden on the school system. So please, I'm urging parents, if your child is struggling, take them to a trained mental health professional in your area. Psychologytoday.com is a really great resource. You can find people that specialize in certain issues. You can find therapists that take your insurance. You can find people that specialize in working with children. So that's a really great resource if people are looking to, like, how do I find a therapist? Psychologytoday.com. Just put in your zip code and different people will show up. Well, this was a really great conversation, Ira. Thank you so much for being here.
Yeah, thanks so much for having me. I really enjoyed it.
Well, before we end, I want to ask you like two questions. What have you learned now that you would wish your younger self knew, or what would you tell your children about what they should do differently that you did, that they should do the opposite of? And then where can people find you?
What did I learn? I think probably what I learned, and I always kind of felt this way, but I think if I went back, I would want to just reinforce the growth mindset earlier on. The idea that like hard work and growth will pay off in the long run. So I think I probably would have instilled that in high school. It probably didn't hit me till I was in college or even a little bit later that I understood how important my work ethic would be in the future of not just my own personal future, but in the future of the people that I was helping. So I'd probably say that, if I think also maybe keeping a network. Recently, I've worked a lot harder on like LinkedIn and other things like that, and that's one of the places you could find me is on LinkedIn at Ira Hayes. It's spelled Hays. But I think in those connections, the connections with other therapists, the connections with other networks, has been more positive in my life over the last like 5 or 10 years. I wish I knew that at 20 or at 25 even, if I would have known how big of a role the kind of collaboration with other people was going to be. I was just kind of like learning. I should have been learning and collaborating earlier on, I think. But people can find it. So it depends. I love when people follow me on LinkedIn. I post a lot about what I'm doing. They can find out a lot about that again at Ira, IRA, and Hayes, Hays. They can check any information if they're in New Jersey and their local Center for Wellness offers virtual and in-person treatment right now. They can go to www.centerforwellnessnj.com. So centerforwellnessnj.com, or my personal website for my private practice is hayshealthandwellness.com. So anytime they want to connect, they can certainly has all my information. They can always reach out.
Wonderful. Well, thank you again so much for this conversation. It was so enlightening. And I think it's so important that we continue to talk about how anxiety and OCD show up differently for kids than it does for adults, because a lot of people don't know what to look for. So thank you for this conversation.
Thank you. Thanks for having me.
Wow, that was a powerful interview with Ira regarding anxiety in children. If you have children that experience anxiety, it's so important to get them help, as early intervention is key for long-term control of anxiety. To learn more about Ira, visit transforminganxiety.com/58. If you enjoyed this episode, please be sure to subscribe and give us a 5-star review, since that'll help others find the podcast. Bye for now.